So this is a pediatric shoulder, right? And again, you're worried, okay, so there's a lot of growth plates here. How do I know what's fracture? How do I know what's not fracture? So you do get growth plates around the neck of the humerus. And again, it's very, very sclerotic as you approach the humerus as well, this growth plate as well. But then people sometimes get worried because, okay, hang on, that's not aligned. That's not aligned. There must be some sort of step deformity here because that goes around like so. How do I know what's going on? How do I figure this out? And the best way I would say is to make sure that you draw a really bad outline of the humeral head. And when I say that is, you can be really accurate and draw that line like so and go around like so, but that's not the way to do it because you have to understand that there's going to be non-radiopaque structure that is sitting within the region of the humeral head. And that's going to be sort of this cartilagey stuff that's sitting there, which you won't see on X-ray. And it's actually going to come out slightly further like so. So the way to try and identify whether someone has got any sort of slip or anything like that is to first of all draw a very bad outline. So I've done a worse outline than I anticipated. So you want to draw a bad outline like so, like you kind of come out a little bit like that, kind of extrapolate a little bit. And then you can actually see it's not going to be likely to be an injury within that region. Also, you might be able to see that there is this radiolucid that's going down like so and down like so. So someone might be like, oh, that's one of the Salter-Harris type fractures. But again, like it's very, very well sclerotic around this region. And also you have to understand that these ossification centers don't ossify uniformly. They don't go outside like this and they ossify and ossify and ossify and ossify. Sometimes you get these stippled sort of areas of calcification. You get sort of areas that calcify, then coalesce, and then eventually become the humeral head that we all know so well. So the other thing is to do when you've got these young peds injuries is to make sure that you can draw along the cortices. You're not necessarily looking for fractures as in cortical abnormalities. Sometimes you're just looking for a buckle, like a bit of a fold within the cortex, which would tell you that this patient has got a sort of buckle injury rather than a full fracture, because pediatric bones are quite soft, quite malleable, and instead of fracturing, what can actually happen is that you can get a bending and a folding of the cortex, which can result in an injury. So some of you may have seen it, don't worry if you haven't, but this patient doesn't have any humeral injury. The humeral head articulates nicely with the glenoid. And again, I'm going to talk a lot about shoulder dislocation stuff as we go through the series of talks that we're going to do over the next few months. But in this particular situation, we don't have much in the way of any evidence of any dislocation. So in this one, what we can see, however, is that the clavicle, which is over here, has got a radiolucent line that goes right down the middle. And you can see that it doesn't quite align the way it normally should. Some of you may be worried about AC dislocations, and that can be very, very difficult in these young patients because they haven't had quite the full ossification of the lateral acromion. And also, when you're at an angle, sometimes it doesn't quite angle up right, and it doesn't look quite. You've got to have dedicated views of the acromioclavicular joint to be 100% sure that there is an acromioclavicular joint injury there. But over here, you can see that there is this radiolucency over here. So what we do when we talk about clavicular injuries is that we split it into threes, right? There's going to be inner third, middle third, outer third. So generally speaking, traumatic injuries are going to happen in the middle third. Very, very common. You need a lot of force to be able to fracture the medial third. It's going to be car crash injuries, things like that. Lateral third can happen, but generally speaking, you're going to have repetitive stress injuries that happen there. You can have destructive bone processes that happen there. Remember, this is a synovial joint as well. So rheumatoid arthritis, inflammatory arthroses, they can all cause destruction of the lateral acromion. This is a very, very common injury and it can happen a lot. Now, remember, when you're dealing with pediatric patients, you'll be super, super, uber careful because you never know, right? There could be NAI, there could be something else. Now, this is a common injury. That on its own is not going to be enough of a thing to warrant a NAI investigation, which is non-accidental injury. But what you need to do is also have a look at the ribs. It's almost negligent not to look at the ribs as well to make sure there's no fractures there. Because yeah, fair enough, this patient may have fallen over, they may have got a fracture there, but if you have multiple old rib fractures and you missed it because you're concentrating on the clavicle and the humerus, I mean, it could be detrimental to the patient in the long term. So very, very important that you have a look at everything else as well, beyond the humerus, the glenohumeral joint, the clavicle, the acromioclavicular joint, et cetera, et cetera. Okay.